Any questions? Anyone?
Kamal, that's an excellent talk. I use Mako as well. I think the issue really is that if we look at the introduction of robotics into industry, it came because it could do it accurately, but more importantly, it could do it more efficiently. So you didn't need to pay for, sick leave and holidays, because you could just put the robots on a production line and they would do the engineering for the company. That's very different in healthcare, because robots at the moment don't reduce time, they increase cost, and they're not as efficient at the moment. So the only justification for robotics will be if there's evidence, or for their wider introduction, if there's evidence that they are clinically better than what we're doing already. So where do you think, what's your sort of answer to that, and where are we in that journey?
Yeah, you're right. At the moment, we are in the very beginning of that journey. The day when automatically, like industrialized automation will come in real surgery is still far away. But for that day to be achieved, we need to work today on the basics of robotics. So we may not be very efficient in terms of timings, saving theater time, because there's definitely increased time at the moment. And in terms of even giving more advantage to the patient outcomes, first we need to prove that we are not making it worse. So that's the basics. The most important principle: don't give any harm to the patient. So keeping that in mind, with these technology, that has been proven that we are not doing any harm. We've been using navigation track technology now for over 20 years. So not doing any harm, plus there have been advantages. A few papers have written about functional outcomes as well, looking at that. And even in our own studies, we had better outcomes. In future, I think these studies will form the basics. Mako, although very advanced at this stage, but I think it's very primitive where it needs to be. So maybe in 10, 20 years' time, it will be at that stage.
Can I ask a question specific to the Mako? So there is no doubt in my mind that it's a wonderful piece of equipment for the acetabular side. And you're done in 2 to 3 minutes, really. But do you think it is useful on the femoral side, and do you use it on the femoral side at all?
Yeah, I use the extended software, so I do the femoral as well as the acetabular sides. On the femoral side, I think it's helpful because you decide your level of the neck cut based on your planning. In the quicker the express software, I think it's not as good because you can't get your anteversion of the femoral stem. So if you can't get the anteversion femoral stem, then you cannot dial that into the combined anteversion. Also, your leg length and offset planning will be, I think, a little bit off because of the way you are registering and tracking the bones. So from my mind, I think extended software is better doing both the sides. What do you think?
So my experience of Mako is I think it's very beneficial in improving your accuracy. I share your view that the extended is better, but the robot is not doing the femur, the surgeon is doing the femur. And so for the femoral side of things with the Mako at the moment, it is navigation really. The Mako is doing this, reaming the socket, and it is assisting you in putting the component in the position that you planned, and I think that definitely has advantages. I don't know where the robotics will go next in terms of actually doing the femur or the femoral preparation. I assume that's the next step in the development. But in terms of the robotics actually replacing us, I mean, that is decades away in terms of positioning the patient, doing the surgical approach. Yeah, so we're decades away from that kind of surgery.
One more question for Kamal. What do you think about the average learning curve for average orthopedic surgeon who's not used for navigation, who's not used to robotics? What do you think is, and the other thing is like the constraints, what you see in terms of economy. Well, it's quite a price tag, you know. Not everyone can afford it. And on top of that, you know, if you got a big learning curve, that for me is a big constraint for adopting that technology.
Yeah, thanks, Rohit. Learning curve, it depends what we call learning curve. If we think of outcome of learning curve as the accuracy of the procedure, you performed is the best as you can, that's what I think learning curve would be, that you get the best results. That there is no learning curve. From the very first case, you will be performing that. But time-wise, if you think of time, taking time to do the procedure, definitely there is a big learning curve. You need to do, with the navigation initially, we did the study, and you needed about 30 cases to get there to your standard time. If you've been using navigation, it's a bit easier to use the robotic, but again, there will, whether you used it or not, there will be increased time in the surgery. My first case took 45 minutes more than my usual time I take. So I had my learning curve, which Stryker people say is about 8 cases, but it is more than that, definitely. I would have thought it'll be about 30 cases before you reach your standard. As far as costs, yes, it is prohibitive at the moment. It's very costly, not every center can afford it, only select few. Although they are still managing somehow to squeeze into the NHS systems and the private systems in UK. But again, having it everywhere in the world is going to be difficult. But I'm sure as the time goes by, as technology grows, everybody has it. These will get cheaper. And when we have smaller sort of sizes, smaller, more technologically oriented, the cost should come down.
The Mako is basically a burr system, and if I'm right, it's used quite extensively in the unicondylar cases, isn't it? So do they have the software for the TKR now, and is it also a burr system or is it a soft?
Yeah, the burr is mainly for unis, as you say. Yeah, now they have both total hip software as well as total knee software. In the total knee, it's saw-based, it's not burr-based. So basically the saw orientates itself to the knee freely without use of any jigs. So you just hold the button and it just cuts.
Got a question, and I'll just enumerate this. Actually, there's a small story which my father keeps telling. There's a person who was going to commit a suicide from Eiffel Tower. So another person who went to stop him, he also jumped from the Eiffel Tower. So the first person asked, why did you jump? Because the first person who was jumping was a good salesman. So the question is, now there are 2 robots in market in India. And to be specific, this is all orthopedic surgeons. One is the Navio and one is the Mako. Of course, 2, 3 are coming in line ASAP. So one is a bit costlier, the Mako, and the other is a bit lesser costlier. So they say that no, this is better, that is better. What we need to make the people understand that what is the difference between the two. One is burr based and image free, and then one is CT based, and it has got, now as Dr. Kamal sir is saying, you can have the reamers, you can have the saw, and what is the difference actually? And can you explain for everybody like which robot is the best or what is?
I'll be committing a commercial suicide if I said which is
No,
better.
nobody is commercial actually, just we need knowledge.
Yeah, between Mako and Navio, as I said, Navio is only image free and Mako is image based. To me, the best part of robotics is pre-op planning.
Yes.
So personally, I would go for the image based one. With the image free, yes, you can do exactly the same intraoperative planning if you're doing a uni knee or total knee. With the hips, I would say having it freehand is going to be a little inferior to the constraints that we now have with the Mako. That's my feeling, because I've been using like navigation in the hips, so that image free, and I've been using the image free software.
Yes.
So that will be kind of just navigation of the hip, if the Navio is used in the.
Yes, exactly. No, it's a bird-based technology.
It's a
actually.
free hand, it's in your hand. Yes.
Yes, actually,
Yeah,
this,
with the bird that they use,
they come
and
out
it
and in.
retracts. If you go into the unsafe area, it retracts back, so it won't cut.
See, I'll tell you one thing. I mean, don't take it otherwise. I mean, we started the Navio platform in 2012 when it was with Bluebells, and we did. Fred Pickard said he used to do it, and it was a nightmare for all of us to assist in the cases because it was bird-based humming sound, and it used to take time. So whenever I was supposed to be with Mr. Pickard, we said, no, if you go, Vivek, you go, somebody go. So basically, Navio.
I will let Fred know.
Yeah, sure. I never liked, but I have all the softwares and the videos because that was something new, and that has been bought by the Navio. I mean, the Smith and Nephew. So basically, Smith and Nephew is a bird-based, image-free system for which your hand is working like a pen, and it says that it will stop. But if your hand goes further, something will happen. Whilst the Mako is a CT-based, and Rosa, when it will come, it will be X-ray based probably. So it has a robotic arm, and I'm very much into IT and all. So software is the same, and what you're using, they have changed it. You can have the saw, the reamer, and even the extended software. I worked on it, so you can do. So second question to all of you is, in this scenario in Patna or in India, cost is high. So basically, क्या ज़रूरत है लेने का? People will say. How do we explain this? The last few statements were very good. If let us be on the other side of the court. If you are the patient, what will you opt for? Is it right investing so much? But at the same time, there are 600 centers in America, more than 70 in the UK, fourth installation of Mako, and so many Navios in India as well. And what generally happens in implants and everything, we follow the West. India will follow America, UK will follow America. So obviously 600 centers within a year will go to 1000, and definitely after 10 years we'll all will follow. So what is your stay on this?
Okay, the guy who invented the computer
Yes.
said there will be only 4 to 5 computers needed in the world.
Charles Babbage, yes.
And now everybody sitting here has a computer in his home. Same goes with the iPhones.
Yes.
They didn't see it coming. But with technology, there are so many things and so many improvements you can make. And the best part is you can measure.
Yes.
If you can measure, you can improve. But if you don't have a measurement, you can't improve. So all the technology that's going forward and forward, like 20 years back, we couldn't think of these things that are happening in this course.
Yes.
There was no communication, no app. You have an app for your course.
Yes.
Do you have that 20 years back?
No.
So things improve with the technology as the time goes by.
What is your say, sir? BD Chatterjee, sir?
No, I think it is very difficult to stop technology from advancing if it is beneficial. So I'm quite certain that robotics will come. I think the greatest plus point is the replicability, and that's the reason I don't use a robot, but I navigate. And the reason I navigate is because you can get the the replicability. You can do the same thing over and over and over again, and your number of outliers will
Yes.
fall away.
Yes.
So economic constraints are, I think, temporary. They are hurdles, but I think they will be circumvented, and eventually I think robotics will be fairly universal, because in our hospital I can tell you that almost 75% urologic procedures are being done by the Da Vinci,
Yes.
and 60% of hysterectomies are done by the robot. So it's well established in the other departments. So it just is a matter of time before it comes to orthopedics.
What is your say, sir?
we have to always keep our finger crossed. Okay, navigation came with the bang, and honestly speaking, those who have bought navigation, they are having dust over it, and these technology has brought few better things. It has also brought corruption in the field, and but I never believed in navigation. We did study at AIMS doing total knee arthroplasty by conventional method, and we took all the CT X-ray and big study around, I think 120 cases. So even if you are a good surgeon, surgery is basically, you should be surgeon by hand, you should be surgeon by mind. If you are good at that, if you are good at eyeballing, in total knee arthroplasty, our outlier within beyond the 3 degree or 3 millimeter, there were only 5% cases.
Very good.
More than 90%, they were within 3 degree. So, but I believe in robo. I believe in robo, probably because in navigation, like कार आपको वहाँ दरभंगा जाना है, आप भागलपुर की रोड पे मुड़ जाओ, किसने रोका? It will direct you, but it will not stop you committing the mistake in navigation. Robo, probably it will stop committing the mistake like cutting your MCL and that popliteal and then posteriorly. So I do not have any faith in navigation, but probably robo, it may have some future, but these things cannot be replaced by good surgical mind, good surgical hand, good eyeballing.
Yes. What is this? Mr. Kalam?
I think robotics is here to stay. I think at the moment it's pretty limited in what it can achieve. I think, as I said before, I think that it will be an assist to us. I think it will be many, many years before it will replace us. But I think it's here to stay. I think cost and efficiency is a big thing, and that's certainly been part of the limitations in the UK. So I don't know. I think it's a bit of a marketing tool at the moment. I think it drives practice in the private sector. Private hospitals in the UK, if they haven't got a Mako, and there's another hospital down the road that has, I see patients drifting there, which is rather than evidence-based, it's marketing-driven. That often happens in orthopedics, but in time the truth wins out, and if it is an advance, it stays. I think robotics will stay because I think it is an advance, but it will take time before we can fully demonstrate that.
See, I personally feel the technology, when it comes, it has to be affordable. So if you look at iPhone, when it was like 1.5 lakhs, nobody can afford it. But when the prices come down, the people can afford it and they can see the use of it. So it has to be affordable. Second thing, it has to show results, which I think robotic surgery is showing results, but how the clinical outcomes of the patients improve, that we need to see. Okay, you can get the center of rotation right, 1 millimeter here or 1 millimeter up and down. It do matter, but whether it can be reflected in the clinical studies, this has to be shown.
Yes.
Kamal has been always early adopter for
Technology.
but there are like midterm or late adopters as well. So it has to, you have to see the balance, the risk or benefit for the technology. So I think they are going to stay, and probably they have got advantages, but whether it reflects on the clinical outcomes of the patients, we need to see that.
Yes, please.
Yeah, so I want to know, with especially with the Mako and with the single radius striker knee, have you switched from Insol's mechanical alignment concept to the kinematic alignment concept of Hollister and Halloway?
Right. One thing is clear, that not everybody's mechanical axis is straight. That we all know now. So I would accept 2 or 3 degrees on either side. depending on the patient's original anatomy and their own alignments. In terms of the kinematic alignment, I don't think it's kinematic. You are doing it on the scans, thinking this condyle would have been shaped like that before it was borne out. So I don't agree with that concept. It's done on static images with presupposed plan in the mind, so it's not true.
So that means it is difficult to conceptualize the pre-morbid state. That's what you're saying.
Basically, everybody is doing mechanical alignment for last 30 years, and even total hip, total knee arthroplasty. 80% joint, they are surviving more than 20 years. So it is a fantastic result. That's why this surgery is popular all over the world in orthopedics. So that is most important. Good surgery, even without these technologies, it may bring some change.
So anyway, should we end this session because we have few more sessions. I would like to felicitate Dr. Thank you. Next session details. I hope you all enjoyed because congratulations, sir. And